प्रीति मैम शुरू कर लो।
नहीं तो वो उन्होंने कहा ना स्टॉप करो शेयरिंग।
अच्छा,
तो उसने क्या बोला था, आपने मुझे शेयर करना है या ही शेयर?
नहीं उन्होंने कहा आप ही को शेयर करना है।
अच्छा, तो फिर मेरा स्टॉप शेयर क्यों कराया?
100% पता नहीं, मैं एक मिनट उसको।
हाँ, एक बार वापस पूछ लो, अदरवाइज
So
मैं
we
तो।
can start the program, ma'am.
So shall I start with the module or will you share?
You have to, madam. You have to share the screen.
So okay. So welcome everybody. And
Madam, sorry to interrupt you, ma'am. Madam,
Huh?
click on. Sorry to interrupt you. Click on this enable editing, madam. It's not in full screen. Click on this enable editing button. Then go to slide full screen.
Which button are you saying?
Enable editing, madam.
Enable editing. Okay.
Click on that. Then go to slideshow, madam.
Slideshow.
Home, insert, top, slideshow. After that. Home, insert.
Home, file. Home.
Insert, draw.
Design, transitions, animation, slideshow.
Slideshow. Click on this first, madam, from beginning. From beginning, madam. Come complete left side, madam. Come complete left.
नहीं, स्लाइड शो के बाद में
बिल्कुल बिल्कुल लेफ्ट में रखा हुआ है फ्रॉम बिगिनिंग। स्लाइड शो में बिल्कुल लेफ्ट में फर्स्ट जो है, स्लाइड शो में सबसे पहले वाले पे जाओ, लेफ्ट साइड में
स्टार्ट स्लाइड शो है। अच्छा,
फ्रॉम बिगिनिंग। हाँ
यस, ओके, आई थिंक
Now it's full screen now.
हाँ, यस। So I welcome you all today to a very important module this afternoon, which we will be studying. Respectful abortion care, which is a joint FOXI and WHO initiative. And this is a Master Trainers Orientation virtual program. This medical termination of pregnancy, MTP Amendment Act 2021 is what we will be looking into. Respectful abortion care is the right of all pregnant women in our country. It's a legal right, irrespective of their marital status. So, what is the objective of this module? It is to disseminate evidence. We will take a closer look at what are the new laws and what are the changes in rules. Unsafe abortions in India lead to mortality, morbidity, and hamper women and girls' full participation in society. 8% of maternal deaths per year are due to abortion, making it the third leading cause of maternal mortality. Nearly 2 out of 3 abortions performed are deemed unsafe, and nearly half of the pregnancy-related deaths are in women and girls under 24 years of age. See how young. When is abortion considered safe? WHO's definition of safe abortion is by appropriate methods and by trained persons. It is less safe if only one criteria is met, and unsafe if both criteria are not met. Medical termination of pregnancy amendment, safe and comprehensive care is mandated by law. The salient features of the MTP Amendment 2021, modification and requirement of provider. Previously, requirement of opinion of one provider for MTP up to 12 weeks and requirement of opinion of 2 providers for MTP for 12 to 20 weeks. But now the amendment has been done, which there is requirement of opinion was for 1 RMP for termination of pregnancy up to 20 weeks and requirement of opinion of 2 RMPs for termination of pregnancy 20 to 24 weeks of gestation. So the potential outcome here is the increase in the number of facilities, especially in the public sectors like PHC, because often there's only a single gynecologist available there. and there could not be a second opinion. The other salient features, previous act had provision for termination of such pregnancies up to 20 weeks. The upper gestational limit does not apply in cases of pregnancy with substantial fetal abnormalities diagnosed by a medical board. So the potential outcome is increase in access to safe and legal abortion services, who often seek these services late beyond the legal limit for termination of pregnancies with substantial fetal anomalies diagnosed late, thus reducing unsafe abortions and court cases. Currently, if anomaly was diagnosed late, one had to go to the court to take permission for termination. Then there's a modification related to marital status. The condition of failure of contraceptive was previously applicable for only married women or her husband. But now the condition of failure of contraceptive is to be extended for any woman or her partner. The potential outcome here is increased access to safe and legal abortion for any women, irrespective of the marriage age, especially with upcoming changes in legal age of marriage, an important advancement for increasing access to safe abortions. We so many times have adolescent girls seeking abortion. Then the previous act said the Medical Termination of Pregnancy Regulation 2003 mentioned that information should not be disclosed except under the authority of law. But the new insertion says that name and other particulars of the women whose pregnancy has been terminated shall not be revealed except to those authorized by any law for the time being in force. The potential outcome is increase in privacy and confidentiality of abortion seekers. So, sorry. I have to go to the previous slide. How do I go? So increase in privacy and confidentiality of abortion seekers. So there's more need to safeguard rights and dignity of women and provide respectful, bias-free services, including counseling and contraception. To the extent that nowadays we don't mention the name of the patient on the case sheet, it's only mentioned by a number. Law salient features of MTP Amendment Act includes prioritizing confidentiality and safety. Name and other particulars of any women seeking abortion to be confidential, except to a person authorized in any law for the time being in force. The ground of failure of contraceptive has been extended to women and her partner. Now, the amendment defines special or vulnerable category of women eligible for extended gestational period for termination of pregnancy from 20 to 24 weeks. The norms of RMP whose opinion is required for termination of pregnancy at different gestational age has been revised, and the powers and functions of the medical board. The obstetrician, gynecologist, pediatrician, plus radiologist when available, formed for each state and mandated to provide timely evidence-based decisions. So this is when we are terminating pregnancies for more than 24 weeks. Now, special category of women who are eligible for MTP more than 20 weeks. Women with physical disabilities, major disability as per criteria under the Disability Act, the change of marital status during the ongoing pregnancy, like widowhood or divorce, and if the female decides not to continue with her pregnancy. Women with pregnancy in humanitarian settings, disaster, and on emergency situations as declared by the government, like what is happening in Ukraine today. Survivors of sexual assault, rape, or incest. Whenever they report, we can do an abortion on them. Then the fetal malformation substantial risk being whenever the fetus is incompatible with life, or if the child was, if born, would suffer from such physical or mental abnormalities to be seriously handicapped. All minors and mentally ill women, including mental retardation. So all this, for all these women, we can do abortions for even at a later age. Then norms for RMP. Now, what is an RMP? Medical practitioner. In the old act, it was an MBBS or more with a medical practitioner who had assisted in 25 cases of MTP, of which at least 5 were done independently. So one had to do an MTP training, or a medical practitioner who has completed 6 months of house surgency in obstetrics and gynae, or a medical practitioner who holds a postgraduate degree or diploma in obstetrics and gynae, or a medical practitioner who has experience of at least 1 year in the practice of obstetrics and gynae. 1 RMP opinion up to 20 weeks, 2 RMP opinion 20 to 24, and medical board when beyond 24 weeks. So this was the previous act. Now this amendment says, under the amendment rules, an additional category of provider has been added for termination up to 9 weeks with medical methods. RMP with experience in practice of obstetrics and gynecology at any hospital for 3 months. Training with performance of 10 cases of MTP by MMA under supervision of an RMP in a hospital, or maintained, or a training institute provided for this purpose for the government. So anybody who has some experience in obstetric gynecology and plus is also able to do this manual aspiration is the one who can give oral tablets for MTP. Then again, 1 RMP opinion up to 20, 2 RMP opinion 20 to 24, and a medical board opinion beyond 24 weeks. The norms of RMP whose opinion is required for termination at different gestational ages. Till 9 weeks, experience and training is requirement for RMP. Experience at any hospital for 3 months in practice of obstetrics and gynecology, or has independently performed 10 cases of MTP by MMA under supervision of a RMP in a hospital established or maintained, or a training institute approved for this purpose by the government. A practitioner who has assisted a RMP in the performance of 25 cases of MTP, of which at least 5 have been done independently. Then third, a practitioner who has a postgraduate degree or diploma in obstetrics and gynecology. A practitioner who has completed 6 months of house surgency in obstetrics and gynecology, or a practitioner who has been in any hospital for 1 year training in obstetrics and gynecology. Then till 12 weeks, experience and training requirement for MTP. A practitioner who has assisted an RMP in performance of 25 cases of MTP, of which at least 5 have been done independently in a hospital. And secondly, practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology, a practitioner who has done more than 6 months of house job in obstetrics and gynecology, and a practitioner who has experience at any hospital period of not less than 1 year in the practice of obstetrics and gynecology. So here only 1 RMP is required. So till beyond 12 weeks, till 20 weeks, experience and training requirement, a practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology, practitioner who has completed 6 months of house surgency in obstetrics and gynecology, and a practitioner who has worked in any hospital for more than 1 year in the department of obstetrics and gynecology. Here again, only 1 RMP is required. Then between 20 to 24 weeks, those who are qualified to do an abortion are people with postgraduate degree or diploma in obstetrics and gynecology, people with 6 months of house surgency in obstetrics and gynecology, or a practitioner who has worked in a hospital in the department of obstetrics and gynae for more than 1 year. And here opinion of 2 RMPs is required between 20 to 24. Beyond 24 weeks, we require a practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology, and a practitioner who has worked in the hospital in OBGYN department for more than 1 year. Opinion of medical board is required for the termination procedure. When advised by the medical board, is carried out with all safety precautions along with appropriate counseling and at an approved place. So, the composition of the medical board includes a gynecologist, a pediatrician, and a radiologist or a sonologist. Powers of the medical board to allow or deny termination of pregnancy beyond 24 weeks of gestation period only after due consideration and ensuring that the procedure would be safe for the women at that gestational age, and whether the fetal malformation has substantial risk of it being incompatible with life, or if the child when born would suffer from such physical or mental abnormalities to be seriously handicapped. Co-opt other specialties in the board and ask for any additional investigation if required for deciding on the termination of pregnancy.
Stop sharing करना पड़ेगा मैम.
Stop कर दिया.
Can everyone see?
Yes.
So I have to speak on safe abortion techniques. What are the update in technology regarding respectful abortion care? It's a joint effort of FOXI and WHO. Session's overview is what are the existing guidelines? We have to assess patient prior to abortion, medical methods of abortion, and what are the surgical methods of abortion.
तब तुम्हारा full screen है क्या? Is it full screen?
Full screen तो किया है मैम, नहीं दिख रहा है क्या?
Full screen only, ma'am.
हाँ.
Okay.
Yes.
These are the national guidelines on safe abortion. Law has changed from 25th March 2000 to 25th March 2021. So all guidelines have 3 keys in management of abortion safely. Number 1 is pre-abortion care. We have to take care what are the prerequisites before abortion, what are the methods of abortion, and what is the aftercare. After the abortion, we have to take care, and post-abortion, we have to counsel for contraception as well. So pre-abortion assessment and counseling, it's very important. So what we have to do is we have to take detailed history. We have to examine the patient, general physical examination and pelvic examination, lab and other investigation, if whatever condition, whatever are possible methods at that time. And decision making information on abortion, which type of abortion we have to go according to the size of the sac. So gestational age determination by LMP, what the patient is saying, or physical examination, because at time patient is not well educated and she cannot tell proper LMP, or maybe she is confused about her last period. So we have to thoroughly examine physically and pervaginally. So we can examine, and the uterus size. This is the detailed graph which is showing what is the uterus size at what age. At 12 weeks, we can feel uterus from abdomen. At 16 weeks, at midpoint between symphysis and umbilicus, and 20, it is just below the umbilicus and later on. So there is always a limitation. This is very important to know, because the size of the uterus, what we are seeing is not always justifiable with the size of pregnancy. Because if there are malformation of the uterus is having some fibroids, there is multiple gestations, or there is retroversion of the uterus, patient is very obese, there is some pregnancy. So these are the criteria in which
शुगर कंट्रोल नहीं हो. अब आप जब ट्रीटमेंट लेंगे ना इसके लिए तो साथ में शुगर कंट्रोल करें तो आप
प्लीज अनम्यूट कर लो. So first we have to do pre-abortion investigations. Pregnancy test number 1, because we have to confirm the patient is pregnant. If patient has done already, then it is okay, we can see her card, or if it's not done, then we'll do the pregnancy test. Then we have to do hemoglobin minimum investigations so that to rule out patient is anemic or not. Then RH test, blood group test karna hai, because we have to see if the patient is negative, then we have to give NTD also. HIV test and hepatitis B also, and then examination. Other laboratory tests like medical history or sonography will do if possible. We have the possibility of those tests availability. So pre-abortion counseling, we have to ask patient why she wants termination of pregnancy. Then what are the safe methods of abortion, importance of trained provider performing the procedure for her safety and for her health and hygiene, available methods of abortion, risk and warning signs. Without contraception, she can get pregnant as soon as 14 days after abortion. This is very important. We have to explain to the patient. Resumption of her normal activities during, including sex, intercourse, and follow-up. So what is important is documentation. Informed written consent we have to take, and decision to accept that she has to take contraceptive devices or counseled to be taking some contraception post-abortion. So clinical management of abortion, see if the abortion, we have to raise if the pregnancy is less than 12 weeks, if pregnancy is more than 12 weeks. So in case of less than 12 weeks, according to FOXY recommendation, we can give medical abortion pills, mifepristone and misoprostol, or misoprostol only vacuum aspiration. It all depends upon how we have to do according to the size of the pregnancy. So if it is 7 to 9 weeks only, then we can go with medical abortion, mifepristone, misoprostol. Or if it is more than that, then we can, if the patient, we can give only misoprostol, 800 milligram, sublingual or buccal. All depends how much the pregnancy is. If it is more than 12 weeks, mifepristone, misoprostol only, dilatation and evacuation, all depends that patient has come in what situation to you. But in case of DNC, it is always a blunt dilatation and curettage. Clinical assessment, clinical management of abortion, the first methods of first trimester abortion, then we take it is medical or surgical. So tablet mifepristone and misoprostol is given for medical abortion. So we should know what mifepristone is going to do and what misoprostol is. Mifepristone is antiprogestin, so it inhibits the effect of progesterone. So pregnancy is not continued. Whatever age of pregnancy is, it stops there only. Then mifepristone works by softening of cervix and enhancing the contractions of uterus, so that whatever sac is there, which is not growing now, it is pushed out. Protocols of mifepristone and misoprostol. Day 1, mifepristone is administered like it's given orally, 200 milligram. And if the patient is Rh negative, that we know by initial prior investigations, then we have to give NTD 50 microgram. Day 3, mifepristone administration is given. After mifepristone administration, up to 7 weeks, 400 microgram misoprostol, 2 tablets of 200 each. Means 2 tablets. 1 tablet is of 200 microgram. So 2 tablets sublingual, buccal or vaginal or oral, whatever patient is comfortable with. And just a minute. Or 7 to 9, if the pregnancy is 7 to 9 weeks, we can give directly 800 microgram sublingual, buccal, vaginal. And in addition, what you have to do is, we have to give analgesics, because we have to explain to the patient with this, when uterine contractions are there painful, so she might feel nausea, so we can give antiemetic also, and we can give analgesics also. We have to explain and offer contraception, because when she has come for abortion at this time, she will not like to have abortion next time also. So how can she protect herself? We have to explain. Characteristics of different routes of misoprostol administered for first trimester abortion. If we are giving orally, the pills are swallowed. Recommended for 7 weeks of gestation. For further more than 7 weeks, the chances of incomplete. So what are the side effects? It's diarrhea, nausea, fever, and at times fever goes up to 102 also. If we give buccal, means pills are placed between the gum and teeth. It's placed there, and sublingual is when it is placed under the tongue. Buccal means pills are placed between the gums and cheek, swallowed after 30 minutes. It also have more fever. But sublingual is when it's placed under the tongue for some time, and after 30 minutes is swallowed. There are also chances, because it is fast absorption, there are chances of fever, chills, and diarrhea. When pills are placed in vagina, vaginal pharynxis, then it is very safe, because they are lowest rate of side effects. So WHO regime, dose schedule, and medical abortion, we have come to know. So if in less than 12 weeks, the abortion is induced, mifepristone, misoprostol, and misoprostol only 800 microgram. Vaginal bleeding occurs in 2 weeks. It continues up to 2 weeks in normal after medical abortion. So we have to explain to the patient, see, the bleeding may continue for 15 days. Don't panic. Services should be available at the primary care level with referral system in place of all required higher level care. Additional services may need to be provided to individuals seeking medical abortion. As such, we have already discussed counseling, testing for STDs, HIV, abuse support services, psychological or social services, and specialist health or medical services. We have to give iron those who are anemic, and we have to explain about pain medications and emotional trauma, whatever she is having because of abortion, we have to counsel that also. So what is follow-up care? Routine follow-up not necessary, following an uncomplicated medical abortion using mifepristone and misoprostol, but we have to explain to them what can happen. A follow-up visit of 7 to 14 days after the procedure may be offered to provide contraceptive counseling and services, emotional support, or address medical concerns. A routine follow-up visit is recommended only in case of medical abortion using only misoprostol, or assess success of abortion. Follow-up care. Assess women's recovery. Ask for any signs and symptoms of ongoing pregnancy. We have to ask whether still she is having some nausea, some problem, if there was what was the amount of bleeding. Review any available medical records or referral document, whatever she is having earlier. Ask about symptoms experienced since the procedure. Perform a focused physical examination for any complaint, whether she is complaining of any fever or pulse, tachycardia, and assess women's fertility goals and need for contraceptive services if not provided earlier. So what is the summary? First visit, day 1, physical examination, pelvic examination. We have to confirm the diagnosis of pregnancy, tablet mifepristone 200 milligram orally, offer NTD if the patient is RS negative. We have to ask return for misoprostol administration after 2 days. Contact address and phone number of the facility center, whether she can go in case of any emergency. In case of any emergency or you are not available that time. Record her experience for any side effect on the. What to do on second visit, day 3. See, we have given mifepristone, we have given misoprostol day 2. Now, what to do on day 3? Give misoprostol 400 micrograms sublingual, buccal or vaginal. Observe for 4 hours. Analgesics we can give, and same contraceptive options, condoms, hormonal methods, or whatever patient likes, we have to explain. Tell the woman mean period of bleeding may be up to 15 days. Possible side effects are nausea, vomiting, diarrhea because of misoprostol. Report in case of excessive bleeding. If there is very heavy bleeding, she has to report as early as possible. Pain abdomen or fever. Report if there is no bleeding 24 hours after misoprostol, then it is also important. Maybe it is not worked and the patient pregnancy is still there. What to do? Pelvic examination to ensure. Third visit means when we ask patient to come after 15 days, we have to examine, ensure the completion of abortion, because uterus we will find very much contracted and bleeding almost stopped. Contraception options we have to explain to them and counsel them. Tell the woman about return to the fertility, because she'll be returning to fertility as soon as possible, so she has to be careful. And sonography only if examination shows if there is not a complete abortion. If we feel by PV examination the abortion is not complete, then we have to go for sonography. Now we should know what are the side effects and complications.
Okay.
Pain is there. This is a very good, very important side effect. We have to explain adequate counseling. We can give ibuprofen. If the pain is persistent, then we have to look for some another associated ectopic pregnancy. Still, if we, in PV finding, if we feel the prior giving to medicine, if we feel there is lot of tenderness, then we can early go for sonography. But in case we find at that time it was all fine and now it is very painful, then we can go for sonography, because at times there is a finding there are twins, one pregnancy in uterus and one is in tube. Nausea and vomiting, diarrhea and infection. So we can give antibiotic if we find some problem. If patient is still complaining of fever, we can give antibiotics. If there is failure of medical abortion, then offer vacuum aspiration, or we can repeat the medical abortion medicines. If there is incomplete, which is possible, so observe unless heavy bleeding, repeat misoprostol, offer surgical method of evacuation in case it's not possible. If bleeding resolved, uterus normal size, then the abortion is complete. But if in case initially the bleeding is not much, but later if bleeding continues, so we can go for further misoprostol. If it goes, it's okay. Otherwise, we can go for surgical abortion. Excessive bleeding, please, what have to do? So bleeding more than her menstrual cycle. Soaking 2 pads in 1 hour. Bleeding decreases with time, yes. Then routine care, keep a watch on her vitals and bleeding PV, and she can go home. In case if bleeding doesn't decrease, then watch her vital signs, PV examination. We have to see if there are products of conception in cervical canal on examination. Then woman is stable, then bleeding reduces. Then it's okay. Then observe and monitor. If it is still bleeding continues, then we have to go for sonography. If it is minimal decidual reaction only, then wait and watch. If there are products of conception are there with decidual reaction, then if the woman is stable, we can give another course of misoprostol. If woman is not stable, then vacuum aspiration is the answer. If sonography says that pregnancy is continued, there is no abortion, then vacuum aspiration is the answer. So recording and reporting of medicine abortion technique, since it comes under the preview of MTPA, the documentation is similar to vacuum aspiration procedure. It is mandatory to fill Form C, consent form, Form I-1, RMP opinion, Form 2, monthly reporting form, and Form 3, admission register for case records. Similarly, what we do for MTP more than 7 weeks. Methods of first trimester abortion, surgical methods for abortion, vacuum aspiration, evacuation. Vacuum aspiration is the recommended technique of surgical abortion with pregnancy up to 12 weeks. WHO recommends manual vacuum aspiration as the safest move. It is safest method. The procedure should not be routinely completed by sharp curettage because the uterus is very soft. Vacuum aspiration methods. Procedure of abortion performed is same regardless of type of vacuum used. Handheld aspirator used to generate vacuum. Aspirator is attached to cannula 4 to 12 mm in diameter according to the size of pregnancy. Cannula can be used in multiple settings, including those without electricity. Cannula size corresponds with week of gestation, as I told you. 8 mm cannula for 8 weeks, 10 mm for 10 weeks. Vacuum aspiration methods. Electrical vacuum aspiration can be used, pump, and can accommodate cannula of manual vacuum aspiration, correct size to be. Cervical priming. When the size is more, we need to do cervical priming because it helps in successful aspiration by vacuum. May be considered for women with a pregnancy of any gestation age to prepare the cervix and make it soft and easy to dilate. Recommended method of cervical preparation before surgical abortion is oral mifepristone 200 mg 24 to 48 hours in advance, misoprostol 400 microgram administered sublingually, vaginally, a laminated can be given intracervical to 24 hours prior to the procedure. I think we avoid this these days. Pain management plan for vacuum aspiration procedure, important component of quality abortion care, reduces pain, anxiety, and makes women comfortable. Two components of pain management, non-pharmacological and pharmacological. Non-pharmacological is psychological support, explaining steps that what she has to go, she has to suffer in advance, performing the procedure gently, smoothly, encouraging patient to relax and breathe deeply. Pharmacological source of pain and its management, say anxiety. So we can give anxiolytic, general anesthesia, cervical dilatation, local anesthetics, and analgesics. And if there is uterine cramping, we can give analgesia. So what is the dose? In case of anxiolytics, 10 mg diazepam can be given 1 hour prior to the procedure. And duration of effect is 4 to 6 hours. So we have to explain there may be disorientation and dizziness. This we have to counsel and explain in advance. In case we have to undergo surgical procedure, to 10 ml, 1% lignocaine we can push, or we can give 400 to 800 milligram 1 hour prior to the procedure analgesics. So same thing, patient will suffer dizziness and gastritis she can have because we are giving 400 to 800 milligram of analgesics. So in case of uterine cramping again analgesics we can give, which has effect 4 to 6 hours, but it can have gastritis. Steps of manual vacuum aspiration. Prepare instruments, prepare the woman, ensure pain control, a counselor, explain, perform cervical and antiseptic preparation, administer paracervical block, dilatation of cervix, and then insert the cannula. Suction of uterine contents, withdraw cannula 1 to 2 centimeters away from fundus inside the uterine cavity. Rotate the cannula 10 to 2 o'clock. 10 to 2 o'clock position with smooth, gentle motions. Release the vacuum button on the aspirator. So all the contents will come out. Signs of the uterus is empty. What are? Because we will find the red and pink foam without tissue passing through the cannula. Most of the bubbles we will see in the cannula. Gritty sensation over the surface of the uterus and cervix gripping over the cannula. So softness of cervix, it goes away. There is, we will find a grip on the cannula. Uterus starts contracting around the cannula. So inspect the tissues and procedure with the contraception methods such as sterilization, IUCD insertion can be done simultaneously, and instruments to be soaked in chlorine solution for disinfection. Post-procedure care, monitor her for any complications, provide management. She may leave the facility if she is stable, meet the criteria for discharge, ensure that woman has all necessary information and medications prior to leaving the facility. Documents all outcomes of the treatment, including any adverse events in the facility register and client's record card. Aftercare, management of abortion complications, incomplete, infection, ongoing pregnancy. So we have to explain and we'll do aftercare. Provision of contraceptive methods and offer contraceptive counseling and methods, and assessment of any other reproductive health needs that may be require additional care. So next is follow-up. No routine follow-up unless meso-alone regime is used. So in summary, India has made historic progress in improving access to a safe abortion. That is why we call respectful abortion care. Not much has changed in technical update in last decade. As providers, it is up to us to ensure safety and quality, especially in context of amended law. Along with safety, we also need to focus on respectful abortion services. Every client, public or private, an opportunity to inform, educate, and equip with proper information on contraception and counseling. So you have to register. We have done already, and post-test, please participate in that. Then you will get the certificate. Third module. Anyone want to ask some question?
I'm by the time I organize.
Yeah. Anyone want to ask some question?
You know, all the instruments which are used in MTP, because they are blood stained, they'll all have to be washed in the bleaching powder solution. That's the chlorine solution.
Chlorine solution that I explained, they have to also. Or we can autoclave, we have the facility, we can get every instrument autoclaved also.
Yes, but before autoclaving, well, like immediately after the washing, because they are blood stained, they have
we have to put in
yes, bleaching powder solution. And that bleaching powder solution is not to be used beyond 24 hours. So every morning, a fresh solution has to be produced, like made in the labor room, and then or labor room or OT or wherever. And the instruments are first cleaned there, and then accordingly you can decide with whether you are putting them for autoclaving, or if they are disposable, then you can have fresh ones. Whatever.
Can anybody see my slides?
Yes, ma'am.
Yes.
Yeah.
Madam, a small request, madam. Can you go back, madam?
Me?
Yes, ma'am. Because you have there will be videos in this, so you have.
Yes, please.
There will be 3 videos, madam. So you have to select. There will be 2 tabs while sharing share screen. You have to select share sound and optimize from video clip from share screen option, madam. Then only, if not, the audio will be played, but video will be like nothing. We will not hear anything.
I didn't get you. But come again.
Can you go back, ma'am, once? Stop sharing, madam, and start sharing again.
Stop sharing. Okay.
Start share again. You click on the share button, madam.
Okay.
Then in that you'll have a bottom left. You'll have share sound and optimize for video clip. There'll be 2 check-in boxes. You have to click on this both the boxes, madam. Have you opened the share screen, madam?
Yes, I'm doing.
Go open the share screen, and in that, in the down left side, you'll have two check-ins: share sound and optimize for video clip. You have to click on the both options.
Can you see the video now?
Madam, you didn't share yours. You play the video, madam.
Okay. Is it showing?
It's showing, madam, but video is not
No
playing.
woman should die
Yeah.
due to an
Yeah.
unsafe abortion.
Okay,
And
then
when
stop.
abortion is provided,
Sorry?
it should be given in a
You can
legal
stop the
and
video, madam.
evidence-based manner with quality.
क्या कह रहे हैं समझ नहीं आ रहा है.
You stop the video, madam. शुरू से आप
Stop कर
करिए.
दिया. Okay,
You just
शुरू
go
से
from-
saver tools.
Safety, dignity,
First-
and respect. WHO has a toolkit on safe abortion values,
Madam.
evidence, and rights.
You go
Oh.
from your presentation, madam. First slide से जहाँ से आपका है वो शुरू करिए.
Okay. The first module.
Not the first.
No
module, you
woman
talk
should
about
die
first
due
slide.
to an unsafe abortion. And when abortion is
Go back and select the first slide, madam.
अनुपमा अपनी आपके खुद के जो मॉड्यूल है उसकी फर्स्ट स्लाइड ही से
हाँ वही स्टार्ट करी थी ना मैंने पहले.
दोबारा
वापस
कर दो.
तो इन्होंने कहा कि वो करो
अब में
वीडियो.
आएगा।
कोई बात नहीं, वापस कर.
वीडियो प्ले करने के लिए नहीं बोला था मैडम, वो ऑप्शंस रहेंगे. अगर आप क्लिक नहीं करेंगे तो वीडियो प्ले होगा, ऑडियो नहीं आएगा, किसी को सुनने में नहीं आएगा. तो इसलिए मैं बताया था कि वो सेलेक्ट करने के लिए आपको बस.
अच्छा अब स्टार्ट कर रही हूँ मैं.
हाँ, yes,
Can you see?
yes, yes.
Yes, ma'am.
Okay. Okay, so we've been talking about respectful abortion care, and this module is about safe abortion values, evidence / right or respect, rights and / respect. That is SAVOR. Respectful abortion care is a FOXI and a WHO initiative, and this you are a part of this master trainer orientation virtual program. So this module aims to define respectful abortion care according to the WHO standards. It highlights how norms and stigma affect services, and it provides WHO SAVOR resources for respectful abortion care. That is, each and every provider should be aware of this SAVOR toolkit. So a momentum has been created, the laws have been changed, dissemination needs association and an OBGYN provider support. FOXI is the largest provider base for abortion care. Online training is possible due to COVID, and RAC can reach all providers. The medical management uptake has increased because it is early, much earlier than what was happening later, and previously it is safe, and it ensures that there is no PCP and DT conflation. So patient safety, respect, and quality matters more than ever in the current times, and we all have a role to play in this RAC. So what is RAC, or respectful abortion care? It is adopted from the respectful maternity care recommended by the WHO. It refers to care that maintains safety, dignity, confidentiality, ensures freedom from harm and mistreatment, and enables informed choice and continuous support during and after all types of abortion. So in simpler terms, respectful care means you as a provider and or as a patient treat and are treated with dignity, empathy, and compassion, regardless of your race, ethnicity, gender, socioeconomic status, or reproductive histories. That is the number of times you've been pregnant, or whether you had miscarriages or you opted for abortions, should not stand in your way to respectful abortion care. If you ever feel that something isn't right, speak up. As a health professional, it is our duty to listen and support our patients, and communication is the key. It is a key part of RAC. What are norms and stigma? So stigma and norms perpetuate disrespect and abuse. So remember, don't be biased against your patient. So the category of disrespect and abuse they have been characterized, they've been color coded into those which are mild and gradually into the severe ones. So the physical abuse and intimidating physically is the most severe. Then comes verbal abuse, just even non-consented care, shouting, screaming, and sexual abuse, which we see happening every now and then. Then there should be no stigma and discrimination, which we will elaborate when we come to the Saver Toolkit video. So, and your part comes when you fail to meet the professional standards of care, when you do not make a rapport between the woman and the provider, the health system conditions and constraints are there. So now what is the right of every woman? The right of every woman is she should have freedom from harm and ill treatment. She has a right to information. She has protection against MTP laws and according to the POCSO law, informed consent, refusal, and respect for choices, preferences, dignity, and quality of care. This is a birthright of every woman on earth. Right to timely health care and to the highest attainable level of health, liberty, autonomy, and freedom from coercion. So domains of RAC is being free from harm and mistreatment, maintaining privacy and confidentiality, preserving a woman's dignity, respecting women's choices, engaging with effective communication, soft skills, providing information and seeking informed consent, enhancing quality of physical environment and resources, providing equitable abortion care, availability of competent and motivated care, provision of contraceptive advice and security, continuity of care, and counseling. So now these are the 12 domains of respectful abortion care, and they have been adapted from transforming intrapartum care, that is respectful maternity care. So here, that's how the respect is actually, highlighted. Sorry for this glitch, 1 second. Time to strengthen implementation. Important changes for provider opinion. Patient is an opportunity for respect, and the provider, the onus rests on the provider, and it is our duty to educate and reduce sex-selective abortions. So the implementation of what we've been talking about one provider up to 12 weeks, 12 to 20, you have 2 opinions, and from 20 to 24, you need a medical board. So one provider has more responsibility of counseling and regarding abortion, contraception, referral, and compassionate care. From 20 to 24 weeks, you have to have a need for sensitivity and judgment-free timely services. And they should include all women, as well as special categories of rape less than 18 years and those with birth defects. So we have to prioritize confidentiality and safety. Respect begets respect. So as the safety providers, we need to be mindful of socio-cultural aspects also. So guide to avoid stigmatizing language. WHO Safer Toolkit. This is the guide to avoid this Saver Toolkit is what you can access from the WHO sites. It is available as Saver Toolkit. This as remember, this is safe abortion, values, evidence, and rights/respect. So these are the different websites where we can access the Saver Toolkit. So from the 70s, unsafe abortion to the 2000s, safe abortion, and now 2020s, respectful abortion. There are a few recap questions which we will go through, which you did before registration, and there are some answers to it. According to the WHO, restricting access reduces the number of safe abortions. Is it true or false? So it is false. Just as you were told in the first slide, that WHO definition of safe abortion is a person who fits both the criteria by appropriate method and by a trained person, then only it is safe.
Madam, sorry to interrupt you. You didn't play the videos, madam. There are 3 videos in this program.
That is the trouble. I have only 1 minute. I have only one video with the Saver toolkit.
You,
This comes after this.
okay, madam. Well,
The Saver toolkit video comes after this. I have it as 3B.
okay, madam. Okay then.
Okay. So coming back to the questions, the recap questions, the MTP, am I audible to everybody?
Yes, ma'am.
Yes, ma'am.
Yes.
Okay. So just a minute. The MTP Amendment 2021 requires a minor of less than 18 years to obtain written consent from parents and guardians before she can undergo termination of pregnancy. Is that true or false? So POXO reporting is still needed, but abortion services should not be denied. We need to give bias-free services without any interference. Now, the next question is 30-year-old woman, recently widowed, wants to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy. So the answer is you need, according to the gestational age, you decide whether it is up to 20 weeks, 1, 2 RMP. So this fact is being reiterated into the RAC so that there are no mistakes. And the answer is that it is not our responsibility unless we do it in the correct way of according to the gestational age. It has to be done according to these guidelines only. So in India, abortion is legal. Let us make it safe and respectful. Samarth Bharat, Sampurn Bharat. Samarth is safe abortion made available respectfully throughout health systems. So now let's watch the video. Share.
No woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence.
The video, when it plays, can everybody hear?
Yes, ma'am.
Yes, ma'am.
Okay, so we'll play the video.
Based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO Seva, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO Seva Toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. Seva has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. SAVOR is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
So is that all? Now I think it's the next,
The
the videos are over. Hello?
No, madam. There will be other two videos like
So,
and what? Shall I play those videos, ma'am?
yes, you play them because this is the video that I have.
मॉड्यूल्स कंप्लीट हो गए क्या?
नहीं मैम अभी एक मॉड्यूल बचा है बट आई थिंक दे आर प्लेइंग द वीडियो फर्स्ट.
ओके.
तो no ma'am I think he got disconnected. No, he's a host again.
So what are you saying, Megha? Sorry, come again.
No, I thought he got disconnected in between. So he's starting the video before the module, right?
Huh, no,
He's playing two videos.
2 videos before.
Social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID-19, there are new social norms that are considered COVID-19 appropriate behaviors like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects, and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others, personally and professionally.
Shall I play this video, ma'am? Hello?
Yes,
Ma'am, shall I play this video?
this we've all, haven't we done this? The Saver Toolkit,
Okay, ma'am.
we have done this. I think it's time for the next module.
Okay. Madam, yours is not full screen, madam. Still showing us PPT only.
Is it full screen now?
No, madam.
How is it coming now? Because from my side, it is coming full screen.
Yeah, but sides we can see the PPT side, madam. Just go back and start sharing again, ma'am.
Yeah, 1 minute. I'll just do that. You want me to switch it off and then do it again?
Yes, ma'am.
स्लाइड शो को प्रेस करो.
नहीं, मैं कर रही हूँ, ma'am, but he is saying कि it is not coming full screen. Is it coming now?
No.
Oh, madam.
How is it showing now?
Madam, can you stop share first and again start share, madam? I'll guide you.
दोबारा से स्टॉप कर दो.
1 minute. I'll just do that. Now, can you see it?
Don't share your screen, madam.
I did share it.
नहीं हुआ. शेयर करो.
1 minute, ma'am. I'll just do it again. Now? Can you see it now?
हाँ. बट इसको एनलार्ज करो. बड़ा करो. बड़ा करो, उसको बीच वाले पे लाओ.
मैंने पूरा फुल स्क्रीन कर रखा मैम स्लाइड शो से.
ये जो
अब आ रहा है? तरू मैम, अब आ रहा है क्या फुल स्क्रीन?
नहीं, फुल स्क्रीन नहीं आ रहा है डॉक्टर मेघा. नीचे के वर्ड्स नहीं आ रहे हैं, ये ना वाइड स्क्रीन कर दिया है ये आपने।
पर मैम मेरी तरफ से तो फुल स्क्रीन आ रहा है, बिकॉज आई कैन सी द स्लाइड आल्सो मूविंग। 1 मिनट।
लेकिन वो नीचे के जो वर्ड्स है ना वो नहीं दिख रहे हैं।
मैम हाउ इज इट शोइंग नाउ?
ये वाइड हो रहा है, लैटरली वाइड हो रहा है ये।
मैम ये बनाया ही ऐसा गया है वाइड स्क्रीन में एक्चुअली। बस इतना रखिए और अब फुल स्क्रीन करिए। हाँ
अब आया मैम?
एक बार थर्ड स्लाइड पे दिखाएंगे, थर्ड स्लाइड।
ये थर्ड स्लाइड है मैम, काउंसलिंग।
यहाँ फर्स्ट स्लाइड दिखा रहा है स्क्रीन पे हमारे।
मैम ये फर्स्ट स्लाइड है जिसमें मॉड्यूल 3 भी लिखा हुआ
हाँ,
है।
नहीं थर्ड स्लाइड अगर पूरी दिख रही है, वैसे फुल स्क्रीन तो नहीं है डॉक्टर मेघा, अभी भी लेफ्ट में हमें वो स्क्रीन्स दिख रहे हैं और सेंटर में
कोई
ये।
बात नहीं मेघा, आप इसी पे शुरू कर लो।
हाँ इसी पे कर दीजिए, अगर वर्ड्स दिख रहे हैं तो कोई बात नहीं।
Madam, shall I share the screen? Because your Microsoft has failed to connect
But
the Facebook.
I'll be telling you then to move the screen on, so you will do that?
Yes,
Yeah,
ma'am.
yeah, fair enough. I'll just stop the screen share. You can share it now.
आई थिंक मेघा तुमको ही करना होगा ये। मिस्टर जोसेफ, कैन यू डू इट?
Yes, madam, I'm doing.
Yeah.
ओके।
The screen visible, ma'am?
Yeah,
Yeah,
now
it is,
this
it
is
is.
fine.
Yeah, it is visible. So should I start? Good morning,
Yes,
everyone. Good morning, everyone. I'm Dr. Megha Chandra Shastri from Jaipur, and I'll be now continuing with the second part of module 3, which is yet another very important aspect of respectful abortion care, and that is pre and post abortion family planning counseling. And also we will be seeing in the same module about the various methods by which we can consult a doctor, and also various methods through which we can gain knowledge about the family planning methods which are available. So can we move to the second slide? Before we begin, we must know that the core of any treatment and its positive outcome is correct and appropriate counseling. So what is counseling? Counseling is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open the sharing of their thoughts, their feelings, and perceptions. We'll go ahead. Now, why do we give weightage when we talk about pre and post counseling? It is because counseling is an integral part of comprehensive and abortion services. It is equally important as the procedure itself. Women may need help in decision making, and wherever needed, the spouse should also be counseled. Next. To ease it, we have divided our counseling into two categories, that is pre-procedure counseling and post-procedure counseling. Now, what is the critical role of pre-procedure counseling? It helps a woman to decide about the termination of a pregnancy. It also helps a woman to choose the method for termination. It ensures delivery of complete information about the procedure. And lastly, it also helps a woman to adapt a contraceptive method. Next. Now, what is the correct procedure for counseling? That first, we need to ensure the privacy and confidentiality of the patient. One should not be judgmental and be sensitive towards the patient. We need to establish a rapport with the patient and the relatives. We need to use simple language which a patient can understand and allow a woman to clarify her doubts. If she has made up her mind for termination of a pregnancy, we must assess her for the procedure. Next. Now, along with the procedure counseling, we must also counsel them, the patient and the relatives, regarding the family planning methods. And this should be done before carrying out the procedure. And its relevance would be that once the procedure is done and the family planning method is applied, the patient should know when the quick return of fertility would be there. There is an opportunate time for the contraceptive acceptance by the patient. Minimum 6 months of gap before the next pregnancy should be advised to the patient, and for which the family planning method should be implied. Health benefits and better future outcomes are always there if it's a well-planned next pregnancy. 90% of abortion-related maternal mortality can be prevented by assuring contraception. Next. So now let us see the key factors for pre-abortion family planning. We have divided them into two categories. First, when to start the counseling and what exactly are we supposed to counsel. So when to start the counseling, it starts from the very first visit or a consultation a patient has with you. The only exception being if the patient is in a grief moment, then the counseling can be delayed. Now, what are we supposed to counsel? The importance of contraception. That is when there will be a return of fertility. We help them with the choices of contraception. We specify them regarding the particular method for which they can opt for, and any high-risk behavior if it is applicable. If the woman is not willing for any contraceptive method, we do not refuse for medical termination of pregnancy. Try and counsel her after the procedure is done. And if she is still unwilling to do it, then we can do it on a follow-up visit of her in a week's time, and then we can counsel her. Next. Now, let us just see what are the general guiding rules which are suitable for post-abortal contraception. The abortion process should be complete. There should not be any existing infections. There shouldn't be any injury to genital organs, and the chances of fresh pregnancy should be ruled out. Next. Now, once we are done with the pre-procedure counseling and the procedure also, what is the next most important aspect of RAC is the post-abortal or post-procedure counseling. So what is its critical role? It ensures woman has understood the precautions and the care needed during the post-abortion period. Second, it gives opportunity to counsel for contraception in case one has not been previously accepted any contraceptive method. Third, it reinforces the need for continuing the use of contraceptive method as being chosen. Next. The procedure for post-procedure counseling would be CRR, that is C, to continue ensure privacy and confidentiality. R, reassure her in case of any problems that is occurring. And lastly, repeat the information about post-procedure care and its dangerous signs. Next. Again, we have divided post-abortion family planning counseling into two categories. One are for those who have already opted for a particular contraception and those who are still on an undecided phase. So those who are already opted, we appreciate the choice they have made. We let them know about the immediate care, that is by IUCD and MPAs. If they are taking oral pills, then we ask them to continue the ongoing oral pills. We follow up on a particular protocol. We continue with the reproductive intuitions for the patient and help them to choose a better contraceptive in future if needed. There are particular cards that is being given to the patient in which they know about the contraception, plus they can write the time of the starting of the contraception. In the cases where it is undecided, we need to tackle with the anxiety of the patient if she is having any doubt regarding a particular method. Then the importance of immediate adoption of the contraception and the chosen contraceptives is very important for them to understand. The extended period of adoption might cause them to land up in pregnancy again. So we need to opt an immediate option. A couple counseling would be way better than counseling only a female or a male separately. And if nothing works, we need to tell them about the emergency contraceptive pills. Next. Now we already know the methods which are available and recommended as post-abortion contraceptives. So we will just brush up through them briefly. The first method being barrier method. But before going ahead, we will just see according to the chart, we have divided the methods according to the name of the method, timing for commencement of contraceptive method after the abortion. It has been divided into two categories, the first trimester abortion and the second trimester abortion. In the first trimester abortion, it would be further divided on the method that we have used to terminate the pregnancy. And lastly, we have little additional information regarding the method that we are using. So our first method would be barrier methods. Commonly used are condoms. After the first trimester abortion, it can be started as soon as the sexual activity is resumed. Second trimester, it is same. It can be started as soon as the sexual activity is resumed. The additional information for condoms, it has no hormonal side effects. It can be used without consulting a health provider. It's easily available. It prevents against any sexually transmitted infections, including HIVs. And this is the only method which enables a man to take responsibility of contraception rather than a female. Next. Second method online is intrauterine contraceptive device, or IUCDs in short. It can be either IUCD 380A or IUCD 375. It's a long-term contraceptive method. In case of first trimester abortion, the timing of insertion of IUCD differs according to the procedure used for termination. That is, in cases of surgical method used, IUCDs are inserted immediately or up to 12 days after confirmation of a complete abortion. But in case of medical method that's been used, IUCD is inserted around day 15 of the process, provided there is a complete product of conception expulsion. There is no risk or presence of any infection or any other contraindications are ruled out. But in cases of second trimester abortion, it can be inserted immediately or up to 12 days after the procedure is complete and contraindications are ruled out. The additional information for IUCDs, they are highly effective. It provides long-term contraceptives for 5 years in case of IUCD 375 and 10 years for IUCD 380A. It can be provided by a trained doctor, MBBS and above, ANMs, nurses after first trimester surgical abortions, by trained doctors after medical method of abortions, and by PP-IUCD trained doctors after second trimester abortions. It has no interference with sex, immediate return of fertility on removal of IUCD. It has no hormonal side effects. Next. Our third method are hormonal contraceptions. First in that category are COCs, that is combined oral contraceptive pills. After the first trimester abortion, it can be started immediately or up to 7 days after the abortion is done using a surgical method. But with medical method, it can be started on day 3 with a dose of misoprostol or within day 15 of the process after confirmation of complete abortion. In cases of second trimester abortion, it can be started immediately or up to day 7 after the abortion procedure is complete. The additional information for COCs, they also regulates menstrual cycle. It can be provided by all hair workers after the first screening by a trained provider. There is no interference with sexual activity. It also offers protection against ectopic pregnancy, endometrial and ovarian carcinomas, benign diseases like fibrocystic and fibroadenomatosis. It is not suitable for the women who are breastfeeding babies less than 6 months of age. Next. Second in line for hormonal contraceptions are long-term injectables, that is MPA, that is medoxyprogesterone acetate injectables. It can be given immediately or up to 7 days after the abortion using a surgical method. And with medical method, it can be started on day 3 with a dose of misoprostol. In cases of second trimester abortion, it can be started immediately or up to 7 days of abortion. Additional information, they are highly effective. Confidentiality and privacy are well maintained. It can be provided by doctors, MBBS and above, and also doctors who come under Ayush, by ANMs, nurses after screening by the doctors, that is MBBS and above. For the first injection, there are no interference with sexual activity, no effect on quality and quantity of breast milk, no estrogenic side effect. It offers protection against ectopic pregnancy, ovarian cancer, iron deficiency anemia, and uterine fibroids. Next. Lastly, we have permanent method of contraception for both the partners, males and females as well. Female sterilization, it can be performed after an abortion in the absence of any infection or severe blood loss, immediately or up to 7 days of the procedure, both through mini lap or laparoscopic procedures. In cases of medical termination method that if we have used, it can be done only after the first menstrual cycle has happened. For second trimester, mini lap sterilization can be performed immediately or up to 7 days after an abortion in the absence of any known infection and severe blood loss. Now we have to keep it in mind, laparoscopic sterilization is not recommended after second trimester abortion. Additional information for female sterilization. It's a permanent method of contraception. It's highly effective. It affects immediately. There is no interference with sexual activity. It has no effect on breastfeeding. It has no long-term side effects, and it offers protection against ovarian carcinomas. Vasectomy, that is male sterilization, can be performed on males independent of timing and procedure of the abortion of the female. Additional information, it's very effective. Permanent method of contraception, there is no interference with sexual activities, no long-term health risks, and couple must use another method for 3 months or until unless azoospermia is found. Next. Now, this is to make it easy, we have summed up the timings of starting of the various contraceptive method by this time wheel. As we have already read in the cases where we perform the first trimester abortion by medical method. So we'll just sum up here that in cases of COC, it can be started from day 3 along with a dose of misoprostol or directly from day 15, which is indicated by the stars on this chart. Then we have injectables, that is medoxyprogesterone acetate. It can be given on day 3, similarly with a dose of misoprostol. Then scent or centromin can also be started from day 3 of the procedure. IUCDs can be inserted, as we have already discussed, on day 15 of the procedure with clarifying certain predisposing factors. And lastly, tubal ligation or female sterilization can be done after the first menstrual cycle. Next. Now, this one is the contraceptive wheel for first trimester abortion done through surgical procedure, vacuum aspiration. Now, COCs can be given immediately or within 7 days of the procedure. That is from 1 to 7, we can see it's written can be given. And it goes same for injectables, centromin, and tubal ligation. But for IUCDs, it can be given immediately or inserted, it can be given immediately up to day 12 of the procedure. Next. Now we are done by knowing the methods of family planning. Now we go on the second part of our 3B module, that is sexual and reproductive health services. So what we are going to see in this module are the brief different type of method through which we can telecommunicate with the consultant or other technologies through which we can get the knowledge about our reproductive health. Next. Under teleconsultations, we have various leveraging technologies and service provisions under it are teleconsultations, telecounseling, teleguidance, telereference, and telelinkage. Next. Now, things which are available under leveraging technology, that is via Techno IECR. First, Humdo. It is a website that is designed, developed, and hosted by Center of Health Informatics, that is CHI of National Health Portal by the Ministry of Health and Family Planning Welfare, Government of India. It gives you a choice for planning your family under the National Family Planning Programs. Second, we also have social media handles started by Foxy with the name of Ask Tanu. It's a chatbot service, a digital solution which will enable more women nationwide to seek credible and scientifically accurate health information and make informed choices about their sexual and reproductive health. We also have plenty of videos uploaded on YouTube and various posters, messages, creatives in form of infographics, which one can easily find on net. Then there is a separate helpline number, which you can get by the name Reproductive Health, Family Planning and Infant Health on National Health Portal of Indian website. WHO, MOHF, that is Ministry of Health and Family Welfare, and RCOG provides with plenty of patients' education platforms. Next. Like every other procedure, even the technology has its own pros and cons. And that comes under the term that is called as SWOT. SWOT is strength, weakness, opportunity, and threat. The strength of telecommunication is definitely, we all know, because of COVID era, the telecommunication has increased. That's the main strength. Second, the approach throughout the process is very confidential. And a person becomes very confident when they talk among themselves. The awareness is more through the telecommunication. The weakness, we lack face-to-face communication with the patient. We do lack to some amount the demonstration that we can give the patient physically rather than on telecommunication. Opportunity, the privacy and the comfort is way better than face-to-face. It is cost saving because on telecommunication, you can speak to the consultant who is not even in your city. The number of visits to the doctor and the hospital always cuts down. Now, the threat towards this entire telecommunication branch is a missed opportunity, that you do tend to miss the opportunity to speak to the right person. And sometimes this might lead to misdiagnosis. Next. I cannot read your first line. That screen is coming blank. Can you remove that? Yeah. Applicability of components of CAC, the assessment, that is confirmed diagnosis, and contraceptive needed pre and post abortal during the period and post abortal counseling. Counseling can be through video conferences or through Zoom meetings. The follow-up should be needed. The follow-up protocol should be made and it should be followed. In cases of surgical termination, only one visit is needed, and in cases of medical method that we have used, 3 visits are needed, which we have already discussed in module 2. Next. Now, what are the final key messages? We need to realize the need of pre and post abortal family planning. We need to bring the couple on board and strive for 100% of coverage of contraceptives. We need to capitalize on the basket of variety that we have and applicability of pre-abortal period so that the patient know exactly which contraceptive she should use. As far as possible, we can bring in the technology along in our counseling. And adolescent reproductive health needs both online and offline care. Next. So that would be all. And as a reminder, a certificate will be awarded to all the participants on attending the training and the submission of all 4 forms. That would be the registration, pre and post test, and the feedback. Take home message: in India, abortion is legal. Let us make it safe and respectful. Samarth Bharat, Sampoorn Bharat. Thank you. I think, ma'am, we are done with all 4 modules.
Yeah, yes. Mr. George, I think we can leave. Is it? Or is there anything else? I think the forms will come later on.
Yes, we can finish the Zoom meeting.
And on your mails, you will get this form and you have to fill it in.
The post-test forms.
Yes. So this has been mailed to everyone.
Share the link, madam, in this chat box. Post-session feedback. You just have to click on this link and you will be redirected to post-session feedback, ma'am. Fill and submit and we'll issue the certificates as earliest.
Okay, thank you.
Yes, ma'am.
Thank
Kindly
you.
click on the link, madam, which I posted in the chat box.
Can you please repeat again where to go to? Hello.
There is a 15-question form which they have posted on the chat. We need to fill it and submit, and accordingly, the form would be given to us later on. Is that right?
Dr. Megha, the pre-test was the one which was initially sent along with registration?
Haji ma'am, the one which we were saying that you register and there was a form of 24 questions.
There were questions on it. Yes, that was
so
the
that was a pre-form.
Okay, fine.
Along with the registration, the 2 are already over.
Yeah.
Which we have put in on the web right now in the
got
chat.
it.
Yeah. There are 15 questions. I think that is a post test.
Yeah.
And the feedback, I think, would be what after this?
They'll share it later. Okay.
They will share it later. Yeah.
Posted in the chat box, that's what I'm saying, right? You click on that link, you will be redirected to post and feedback. You just have to submit. I've already posted the link in the group chat.
Right.
It can be, I mean, like this link should be forwarded on the mail of every person. Instead of just in the meeting, I think it should be mailed to all the participants.